Good morning, everyone. Thank you for joining PHCA for today's webinar, Improving Quality of Care Through Better Delegation. I'm Wendy Johnson, Executive Assistant for the Pennsylvania Healthcare Association. PHCA offers monthly webinars to members for NAB-approved credits in order to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and gain better understanding of practical application tools to equip our members so that you may continue to provide the highest level of quality care possible. Before we begin, I have a few housekeeping items to cover. This webinar is being recorded and will be made available on the PHCA website by the end of the day today. The webinar has been approved for 1 continuing education credit for nursing home, assisted living, and personal care administrators. Certificates will be emailed before the end of the day, along with a link to a survey. Please complete this survey, and if you are participating in a group setting, please have each participant also complete the survey. All attendees will be in listen-only mode, and throughout the presentation, you can feel free to submit questions via your questions pane on the right. Our presenters will address them at the end of the presentation. Now for today's webinar. Today's long-term care environment demands more be done with less, and delegation of tasks and responsibilities plays an important role in maximizing the capacity and capabilities of staff. This webinar will provide an overview of the role that both delegation and supervision play in maximizing the capacity and capabilities of staff, provide an overview of common barriers and issues that impact quality of care, and provide practical tips and practices for improving delegation in your organization. Your learning objectives for today's webinar are being able to discuss the differences between delegation and supervision and the role each plays in maximizing the capacity and capabilities of staff, explore common delegation barriers and issues that impact quality of care, and lastly, provide practical tips and practices for improving delegation across long-term care teams. The presentation today will be presented by our very own Don Murr-Davidson, Director of Quality Initiatives here at PHCA. Don, the floor is yours.
Thanks, Wendy, and good morning, everyone. Thanks for joining us on this very important, but I think sometimes overlooked topic of delegation. If you look at the long-term care industry, and I'm going to define that today by looking at nursing facilities, assisted living, and personal care, a large percentage of the care provided to residents is somehow delegated from one member of the team to another member of the team. And more we're asked to work collaboratively across many disciplines of care, so therapy, recreational therapy, nursing, dietary. And so this delegation is not just the nurse to the nursing assistant. I think sometimes if you look at what our personal care aides and what our nursing assistant aides are being asked to do, many times they get directions from a lot of different people, and helping sometimes prioritize and looking at how do we communicate that direction is very important. Similarly, our dietary staff and others. So this is not just a nursing webinar. This is really about delegation across your entire organization. Many people would automatically think of delegation, like I said, from the nurse perspective, or more and more even from like a therapy to a therapy aid delegation. But really this process, as I said, is across the interdisciplinary team. And as we look at some different scenarios today, one of the things, you hear me talk a lot about root cause analysis, one of the things that really sometimes gets to the bottom of why are we not seeing improvement in our quality and why do we not see more success across our journey is that many times we don't do a good job of training our staff on the process of delegation, and so that's what we're going to focus on today. Why is my little thing not working? There we go. So Wendy did a nice job of covering our learning objectives. as many of you start to prepare for the Phase 2 requirements of participation around facility assessment, one of the things that you're looking at as part of that are the services that you provide to residents, and this, of course, is in our skilled area. But across the entire long-term care industry, we're being asked to look at what is the competency level of our staff and what is the right staffing requirement. So all of these things play a part in delegation. You can have a lot of staff available, but if that staff is not well trained from a competency standpoint, or they're not given good direction, your outcomes are still going to, struggle. And so that's why this topic becomes very important. Some of the driving forces behind improving quality in general is, of course, the national and state regulatory themes. We're being asked to deliver person-centered care. So one of the things I'm going to challenge you to think about today is, how are you delivering care today, and how are you going to be looking to deliver care in a year, 2 years from now? Do you put the resident at the center of that care? And how do you look at that from the standpoint of your work processes and delegation across your staff? We're being asked to manage the demands to improve care coordination, and many times we think of care coordination across from discharge from your community to the larger community, back to their home, or hospital to the nursing homes. But this also includes care coordination across your interdisciplinary team. And when you look at where do common deficiencies happen, this is certainly an area where we see communication breakdowns and lack of supervision, so that frequently cited areas oftentimes becomes a break in our internal care coordination process. The other thing that we're being asked to really look at is, are our residents in a safe environment? So when we talk about mechanical lift safety, elopement, some of those big items where both at the national level and at the local level, they're under close scrutiny from our regulatory agencies. Have you looked at your processes around these things? And of course, have you looked at how do you communicate these different areas to your staff that may be responsible for the care? We're also being faced with emerging payment models, and of course they continue to look at outcomes with reimbursement. So whether you're in an assisted living and you're looking to maybe be part of an ACO, or you're part of a skilled care nursing home that is being faced with community health choices, outcomes matter. And part of those outcomes really come back to keeping our residents safe, maximizing their functional levels, and really keeping our residents at their highest level of both quality of life, meaning psychosocial, as well as physically. We also have to do more with less. It's well published about our workforce shortages, and so one of our objectives today is to look at how does the process of delegation maximize your staff capacity, meaning how many staff you need and how many staff you have available to provide the care, but also the staff capabilities, which goes back to the competencies. Many times we'll hear members saying our residents are more sick, they're more complex, they have higher demands. So as part of that, looking at that competency level or capability level of our staff becomes very important. And one of the things we're going to discuss today is, if you have specialty services that you're providing and you have only a certain number of people that can provide that care, it's important that they don't get pulled into providing care that others on the team can provide, that they have that time to concentrate and do those things safely. And then, of course, increase consumer awareness and transparency. We're all aware of the stories we read in the media. We're aware of the public transparency with 5-star and those sorts of things. And, we expect to see more and more of that. I was just at a meeting the other week, and CMS is looking at least one more publicly reported site on quality. So that trend will continue for us. So when we look at quality of care and delegation, specifically in the long-term care environment, many of the care much of the care that's provided to our residents is delegated care. And so when we look at things like catheter-associated urinary tract infection, pressure ulcer, both prevention and healing of pressure ulcers. Decline in functional status. Low blood sugar is one that was specifically called out in the research. Dehydration, constipation, falls with injuries, medication errors. Many of these things come back to delegation of care, and some of the activities associated with that care include turning and positioning, ambulation, hygiene, monitoring of blood sugars, hydration, toileting and incontinence care, skincare programs, medication administration and reconciliation, choking and aspiration. And this is one that we're going to talk about in a few minutes, that you think about all of the steps that happen and all the communication that needs to happen when a resident's diet is upgraded or downgraded, and all of the risks associated with making sure that that resident has the right consistency of food. Restorative nursing, fall prevention programs, and mechanical lift and transfer competency and practice. I think the mechanical lift piece is one that when we meet with Department of Health or when we have members call around significant citations at high scope and severity, that mechanical lift piece is certainly one that we see a lot. So what do our delegation processes look like around that specific task that's being provided, and how do we monitor that it's happening consistently in the right way? So we're going to look at a common scenario, and it's funny, when I was reading the research that this scenario was adapted from, I thought, yep, that was me about 25 years ago when I was a 3 to 11 charge nurse, and kind of looking at what could I have done differently when these types of things happen. So the scenario is you have a 3 to 11 registered nurse who there was a call off on the shift, and she assisted in performing other duties to help out the team. So near the end of the shift, the RN was still going about doing work and found that the RNs and LPNs, the LPNs and nursing assistants had completed their work, and they were sitting at the nursing station waiting for the next shift to arrive, just answering call bells as they came up. And the RN, of course, who had juggled competing patient needs, such as administering IV antibiotics that were assigned to the LPN, assisting the nursing assistant, answering family questions, assisting a physician making rounds, became quite overwhelmed and frustrated because it was now the end of the shift. She was still doing duties, and the rest of the team had kind of caught up. So one might say, well, what was the root cause of this situation, and how could it have been handled differently? Kind of what went wrong? So an immediate response that most people would go to is, well, there were call-offs, so the unit was short-staffed. Well, call-offs happen, and we know that. But what happens, how do we handle when a call-off happens? In this situation, the RN was frustrated. The rest of the staff had completed their tasks. But I can't help but wonder that this scenario, at least with the information that we had, created an environment that placed resident care and safety at risk. Already mentioned, the nurse was multitasking. Did that put her at risk for giving a medication error with that IV medication? Did it put residents at risk for falls? And of course, we all know that when our staff are excited and not quite calm about how the evening is going, that can put us at risk for lower resident satisfaction, lower caregiver satisfaction, and put us at risk for a complaint survey. Oftentimes, too, when the staff is excited, we know that increases the number of call bells. That increases the anxiety for residents. So, of course, all of that contributes to this environment that placed care and safety at risk. The scenario also describes the downside of not delegating and sharing workload. So, again, that RN was frustrated, which leads to burnout, decreased job satisfaction, decreased quality of work. So some questions to ask yourself as we go through the rest of this presentation in the next half an hour to 45 minutes is, what are the barriers to effective and efficient delegation in your nursing center, assisted living, or personal care community? I would ask, have you even really looked at the way you delegate in your organization? Again, research says that This is one of the most common overlooked areas in just how we do business. What are the potential benefits to effective and efficient delegation in your nursing center, assisted living, or personal care community? And what strategies and processes does your organization utilize to promote effective and efficient delegation of care? So that being kind of the challenge for the morning, we're going to look at delegation as an overview. It's not advancing? Sorry, Wendy just handed me a note saying that the slides aren't advancing. Sharing my screen. So I know the slides were sent out to you. I'm not sure why. I'm not sure why you're not seeing the slides. So I'm going to keep going here just for the sake of time. But I'm not sure why you're not seeing the slides. I apologize. So delegation is the decision to transfer an intervention that is within the scope of practice of one healthcare professional, the delegator, who has the authority to perform the intervention, to another on the healthcare team, the delegatee, for whom the intervention is outside his or her scope of practice of employment, but it may be in their job description to perform the duties. Delegation consists of a series of competencies that require a complex skill set and are guided by professional principles. So again, we think a lot of physicians delegating via orders to nurses, the nurses delegating to other staff, therapists, and others on the team in the delegation. Safe delegation depends on appropriate planning and execution of delegated tasks. Wendy just gave me the thumbs up, so whatever I clicked apparently gave you the slides. Steps in the delegation process. So I tried to keep this really simple. One of the things that you need to determine is what can be delegated. So in that scenario with the nurse, what could she delegate and what did she need to perform that only she could do? And then, you know, as a team, they needed to get that job done. You match the projects or the tasks to the staff members that you have. You need to follow up. And then certainly in the case where there's a call-off or someone, you know, is doing a good job, you need to show that appreciation. Benefits to delegation includes it promotes the use of most efficient staff or the most efficient use of staff. And of course, again, with workforce challenges, we're all being asked to do more with less. It's critical that, you know, we provide that safe, quality care in a person-centered environment. So, you know, delegation certainly increases our ability to do that. It assists in transitioning from a reactive to a proactive care delivery model. And again, this is really important. If we feel like we've run around all shift just putting out fires, this enables us to start shifting to a more proactive care delivery model. And it also improves resident, family, and employee satisfaction. So why is delegation so hard? There's actually a fair amount of research that's been done on delegation and long-term care. Unfortunately, most of the research has been done only on delegation within the nursing department. And again, as we've talked about, much of the care we're being asked to provide today is much more collaborative, utilizing the interdisciplinary team, and you know, all of those factors become an important part of that delegation piece. So regardless of discipline, a lot of the barriers are the same. The interpersonal relationships. So the person who's responsible for delegating, what is their willingness to delegate, first of all? Do they have biases against delegation? I think, again, sometimes some of these things become natural. Other times it's more of a concentrated effort to say, okay, we've had a call off today. We need to pull the team together and figure out how we're going to get this work done. Communication style is a big piece of this. And in a few minutes, we're going to look at both leadership styles as well as we're going to spend some time talking about the importance of communication with delegation. One of the other barriers is unfamiliarity with an individual or a team. So if you're a nursing home or a provider that needs to use agency staff, many times that can create some concern about delegation if you don't have trust with them. Or maybe you have a new person on your team and you have to develop that relationship and confidence in what they're able to do. One of the other things is just communication gaps in general. Not having all the information, poor instructions. I think a lot of times around care plans for this. You know, does the nurse aide or does whoever is doing a specific task or duty have the information that they need on the care plan or on whatever tool they're using to provide that care? And then do they have the time to ask questions? Are the instructions clear? So when you're maybe working with the nursing assistants and giving their assignments, do they really understand what those instructions are? Personal choice not to delegate. You know, the RN, back to our scenario, we don't really know, you know, what happened there. We don't have all of the information, but you know, did she have that kind of lack of trust where I'm responsible, so I'm going to try to do more by myself? Did she not have the relationship with her team to pull everyone together? Did she lack the professional development to really pull the team together and look at the duties and do that delegation piece? And then lack of confidence and competency level. And again, we're asked more and more to look at the competency level of our staff. So some strategies to improve delegation in your organization. One of the big things is a lot of this comes back to the leadership within the organization. And since many times we're asked to be superheroes or mythical creatures, I really liked this this kind of breakdown of the different leadership styles. So you can see her on the slide that you have the good king, who their qualities are they set objectives, they give a lot of recognition, they're concise, they're analytical, sometimes authoritative, but they attend to details. Some of their curses are that they're set in their ways. So, you know, as our industry is being asked to change, sometimes it may be hard for them to think out of the box and do things in a different sort of way. So if you think of moving from kind of facility-driven care to person-centered care, are they going to struggle with some of the changes that need to happen there? These folks may not be your biggest cheerleading type of leader, and sometimes that can cause challenges in a situation where, you know, there's call-offs and you need to pull the team together and kind of rally the troops, if you will, to get the job done. The second type of leader is a warrior, and their qualities are that they're inspiring. They might be a little bit competitive, so you might be able to, you know, leverage that talent and you know, kind of use that as a win to get things done. They're confident, they're motivating, and so again, if you know they're as part of their leadership style, some of their strengths. Some of their curses may be that sometimes they come across a little bit aggressive. They may be a little bit overconfident, and again, when you're looking at those interpersonal relationships across our teams and with delegation, this can sometimes create barriers in being successful with delegation. Then we have the medicine woman qualities: visionary, creates change, imaginative. They're out of the box thinkers. Some of their curses may be that they don't appear necessarily organized. And so again, if you think of how you run each of your shifts, you know, if that person maybe is more of that visionary, creates change person, they may need some help in developing skills around being organized so that they can pull the team together to talk about delegating duties to get things done. Then the final one is the great mother, and this person is reassuring, supportive, responsive, very strong at relationships. But this person sometimes struggles to make decisions, so he or she may not be able to determine what's the best things to delegate versus what do they need to do themselves. And sometimes they may be too inclusive, and so that can sometimes slow down the process. So I just thought this was a nice way to kind of tie in leadership to delegation because, of course, it plays an important role in being successful. One of the things that's very well published on delegation are the 5 rights. And for any nurses on the call, of course, there's the rights of medication administration. So this one spoke to me as well. The right direction and communication, the right task. And as part of that is the person who you're going to delegate this to competent. The right circumstance. So if you have a resident that's unstable, who and what can you delegate to for that resident versus a resident who is stable? Is the intervention appropriate? Do you have the right level of supervision? And I think this is a big one where if you think back to some of those duties and that care that we're providing in incontinence care, hydration, some of those things, do we really look at those things with enough of a supervisory eye to make sure that they're happening for our residents to have the best outcome? And then the right person. Again, back to those interpersonal relationships. And what's the culture of the organization? Is your organization an organization that's empowered your team to, take control of a situation and fix a problem for a resident, or does everything kind of have to come from the management team down? So what is the culture of your organization? If we look specifically at a few of the things around a right task, the first picture up here is the nurse or nursing assistant providing fluids to a resident. And one of the more common things, and I hate to say that because we see it too often, is around the breakdown in the process with diet changes. Now, there are a lot of processes associated with resident hydration, nutrition, and dietary needs. But I'm just going to break down this one as an example. If you have a resident who is experiencing challenges with their swallowing, think of all of the people that may be involved and needs to have communication when a diet is downgraded. Think of kind of the places where your communication and delegation system can break down. As I mentioned, this is an area where we sometimes get calls from our members and say, we were cited at a very high scope and severity, and we don't think it's justified. We did everything, and we sometimes have to really take a step back and go, where did that process change? Where did that process break down? Was it from the speech therapist or from the order to the resident not getting the right meal consistency? Was it not communicated to the nursing assistant? Did the nursing assistant not know that the resident who was sitting beside resident B was going to reach over and take something off her plate and put it in her mouth and choke? So all of these things need to be kind of taken into consideration when you're looking at that right task, not just from the standpoint of, the nursing assistant's going to feed the resident, but what's the process associated with ensuring that that resident is getting the right and safe consistency of their meal. The picture here in the middle around you can see a nurse giving an IV medication. There are some services that can't be delegated just by scope of practice or by competency level. So again, ensuring that those nurses or whomever are empowered to do those duties that only they can do and not feel pulled in so many different directions, because certainly medication errors, we've seen an increase, and sometimes it's really, I can't help but think that they get distracted. Many times we talk about, report it to the nurse, report it to the nurse. Certainly that communication is important, but if that nurse is in the midst of preparing an IV medication, that sort of thing, sometimes their focus just needs to be on that skill. And then the final picture over here is someone taking vital signs. And again, the importance of, are those vital signs accurate from a competency standpoint? Are they communicated when they need to be, or are they written down on a sheet of paper or documented somehow, and the nurse looks at them at the end of the shift when it may be too late to do anything, kind of that early intervention piece? And what are the circumstances that the nursing assistants need to report more real time or immediately changes in vital signs? So again, when you think of that right task, it's not just the task itself, but it's the processes associated with safely doing that task. As you can kind of hear, there's a theme here in the right direction or right communication is very important in successfully improving quality with improving delegation. Research has said that the cornerstone of effective and efficient delegation is communication. And I think if we would all agree that communication is probably something we all need to continue to work on improving. Arguably, this is the most instrumental right in shaping quality and safe outcomes. And again, that could be through care plans, that could be through verbal communication. It is defined as clear and concisely describing the delegated tasks. And again, I sometimes think back to my days as a charge nurse or as a nursing supervisor and think of, did I give clear and concise communication? Did I give opportunity for questions, those sorts of things? And then it also includes directions on how the task is to be done. So again, you know, we're being asked to look at these things more and more. The right communication can also be, the right to communication in delegation process can also be threatened just by the information itself. And by this we mean, is the information passed along timely or in a meaningful way? So some examples, of course, comes back to in communicating resident preferences across the disciplinary teams. Again, when we think of person-centered care, who is most likely to know that the resident works 3 to 11 shift and maybe is not going to be up at 5 a.m. in the morning versus they were a day shift person? And how do we individualize their care based on their practices? Another area that I think a lot about is pain management. I know many of you are working on the pain quality measures. And one of the things that we talk a lot about when I go in to work with members on improving this measure is, what's your coordination between your therapy department and your nursing department for your short stay residents who are going to rehab? Do we have good communication? Are we looking at their pain levels? That sort of thing. I mean, that definitely makes a big difference in how that resident is going to perform at therapy, what your outcomes are going to look like, and at the end of the day, as we start looking at some of these new payment models, the length of stay. So are your departments communicating in the best way to manage these sorts of things? And then another one is the change in residence condition. And I've hit the dietary example a couple of times, but you could look at it from exacerbation of, you know, a medical condition, or even just from a kind of getting ahead of a family concern. If the family's in and they have some concerns about care or staffing or whatever, you know, are things communicated so that you can be proactive in responding rather than reacting? With delegation, something that we need to look at hand in hand, of course, is accountability. And this is a nice table on kind of the responsibilities and who kind of shares different components of delegation. It's certainly a two-way street. It's not just the responsibility of the person who delegates, it's also the responsibility of the person who is receiving the instruction. So from the delegator's perspective, you know, you need to make sure that the resident is appropriate to have certain things delegated. You need to decide what can be delegated. Determine if that person you're delegating to is competent, and then provide appropriate supervision, which would be including the opportunity for people to ask questions. As the person having the task delegated to, do you have sufficient knowledge to perform that task? And if you don't, you have the responsibility to say, I'm not competent to do this, and ask for that responsibility to be, done, assigned to someone else. You have the responsibility to follow policies and procedures. And again, we see probably, a lot of breaches in this as it comes to infection control, use of mechanical lifts, and transferring. So following those policies and procedures, knowing those policies and procedures. Perform the intervention safely, effectively, and ethically. More and more we're being asked to look at if an incident happens, is there a tie to an abuse neglect investigation? So, again, we're all responsible for the safety of the residents. Documenting the care. And this means not just clicking a box at the end of the shift, but truly documenting what care was provided and ensuring that it's per the care plan as well as the policy. And then reporting observations. This really helps us to stay ahead of, either a change in the resident's condition from a clinical standing or from a complaint setting. And then the employer has the responsibility to establish guidelines for care, ensure there is adequate staffing to provide services. And again, this goes back to that facility assessment that you're all looking at. What's the staff that you need to provide the services that you're giving, whether it's dementia care, what I'll call high-tech or clinically complex care, rehab, all of those sorts of things. Ensure that you have established written policies and procedures, and this would include delegation. Again, some of this may be determined by job description or scope of practice, but ensuring that it is covered there. Ensure competency levels of your staff to provide the services, and then ensure that there is a process in place to establish and maintain competency, not just that they've been checked off on the skills list and then they don't do a certain skill for 6 months. I mentioned a little bit around the relationship between collaboration and delegation, and again, this is an expectation of care. Some of the specific departments are here on the slide. We think of the physicians and their delegation to the nurses and the rehab team, registered nurses, and then therapy. Principles of collaborative practice. Many of these are similar to your 5 rights of your delegation. Trust and respect. It's important that the members of the collaborative team have a basic understanding and respect for each other's roles, and that there's trust that they'll consult and collaborate with each other. Effective communication, there it is again. Collaborative practice and central to providing safe, quality care. Client safety. This is at the center of everything that we're doing. Keeping those residents at the center of what we're doing, providing care in that safe environment. Staffing, again, and this is part of that facility assessment. Are you having the competency and right level of staff for the services that you're providing? And then really focus on engaging your residents and your families, that person-centered care. I would be remiss in talking about delegation if we didn't talk about team assignments. Team assignments are never as easy as just kind of putting them on paper, and sometimes throughout a shift, these assignments may need to be adapted and adjusted. A resident condition can determine that. Perhaps a resident has had a change or they're having a bad day. The services required and competency, again, making sure that who you're doing those assignments to are at that level. If you have a new nursing assistant, they may not be as efficient in providing PM care as your more experienced nurses. So what does their resident assignment need to look like compared to others on your team? And then I think one of the ones that I've been in a lot of different buildings, and some are much better about thinking about their environmental layout and the assignments, but are you doing an assignment in a way that makes the staff efficient, or are they running all over the place to try to take care of the residents? I think the other thing that's not on here, and maybe it's because it's part of that person-centered care, is do you know the residents and take into consideration the residents' preferences when it comes to making those team assignments? Some considerations for unlicensed staff, and this is maybe a little bit more nursing specific, again, is those residents need to be assessed and have that determination made for the interventions. A lot of times this is outlined in the care plan. Do our new nursing assistants know where to find this information? Again, this is one of the common things that we see cited when it comes to care planning. Resident conditions, are they stable? I know a lot of times you may get multiple admissions on a shift, so kind of quickly assessing what those new residents are and are they stable, who can provide that care, as well as maintaining the residents who are on your units for a long period of time. The competency piece again is on here. We just can't get away from that one. Interventions consistent with duties as assigned in their job description. We need to make sure that we're not delegating things to unlicensed staff that it's not part of their job description. Even though they may have done it somewhere else, if it's not as part of their job description, you have to watch that you're not putting yourself at risk. And then, of course, adequate supervision. So some key takeaways here as we kind of start to wind down. Assess the patient to determine their condition, provide direction, be available for question. This promotes a learning and collaborative environment. Delegate tasks that are within the scope of practice, competency, job description, and their skill sets. Supervise, observe, and monitor activities that are delegated, and evaluate the effectiveness of delegation. So let's revisit our 3 to 11 nurse scenario and kind of utilizing those rights of delegation, relook at this scenario. So 3 to 11 nurse assisted in performing work that could have been completed by others on the team. So that call-off occurred. Did he or she pull the team together to determine a plan to maintain resident safety and provide quality care? Near the end of the shift, while the rest of the team had wrapped up their work, she was still, running around. One of the things that struck me is, did that staff offer to do anything for her? And you can tell by the end of the scenario, it kind of became an interrelationship piece where they couldn't read her mind, but they also didn't initiate that, can we do anything for you? So it goes back to that interpersonal relationship, and it's that a two-way communication. Does the RN have the process and skills to appropriately delegate? And that goes back to some of the common barriers, some of the baggage maybe that they carry. Do they know their team? Do they know who they can trust? And do they have comfort level with their skill set? So much of this ties back to the culture of teamwork, leadership, and those interpersonal skills. I've mentioned this a few times throughout the presentation about person-centered care, and this really is something that doesn't happen overnight. When you think of institutional care, the way that, for a long time many of us have provided care that's more task-oriented, it may at times be very fragmented, it's schedule-driven, you have to be at therapy by 8 o'clock kind of thing, and that one-size-fits-all model. We're now being asked under the new requirements to provide individualized care, which is more care delivery systems based on the needs of the resident. And we need to focus on the abilities and strengths of that resident. So again, this type of thinking doesn't happen overnight, and it takes some time to develop those. And as you kind of go forward in preparing for the Phase 2 requirement, this piece around delegation and competency and the staffing all needs to be considered as part of your facility assessment as it relates to the services that you provide. So with that, we have plenty of time for questions. If we have any questions, Wendy, I will turn the presentation back over to you.
Thank you, Dawn. for the great information today. We really appreciate it. At this time, we'll open up the question and answer portion. Please submit your questions using the question box on the right-hand side of your screen on the GoToWebinar pane. And we'll give it a couple minutes and see if any questions come in. All right, not seeing any questions yet. If anybody has any questions, you can type those in and we'll get them answered. Otherwise, keep an eye out for the next round of webinars. We're working on scheduling those, and we'll get information out shortly on those. Keep an eye on your email and in the blogs and on our website. All right, I'm not seeing any questions, so just a reminder that your certificates will be emailed before the end of the day today, and a recording of today's presentation will be made available on our website at phca.org. Please take time to complete the survey that will be emailed. Thank you again, Dawn, for presenting on this topic. Have a great day, everybody. Thanks again.
Thanks,